If you are a senior adult who has taken low-dose aspirin every day for years, you face a new, critical decision. The medical guidelines have changed. For millions, that trusted daily pill is now considered an unnecessary risk. But there is a hidden danger in stopping it. It's a danger most doctors fail to warn patients about. It's called the rebound effect. Stopping low-dose aspirin abruptly can trigger a temporary, high-risk state of hypercoagulability in your blood. This means you could face a short-term risk of a stroke or heart attack far greater than if you had simply kept taking the medication. That is the hidden threat in what should be a healthy choice. Today, we are not going to debate whether you should stop, but how you can stop safely. We will not move forward until you understand the science of the rebound effect. And I will give you a detailed 4-step safe stop protocol to take directly to your physician, ensuring your transition is managed with the care your health deserves. The primary versus secondary trap. Before we discuss safely stopping, we must make a crucial distinction that most patients miss. Aspirin is not a single drug. It is a tale of two different purposes. For secondary prevention, aspirin remains the gold standard. If you have already suffered a heart attack, an ischemic stroke, or you have documented coronary artery disease, please understand this clearly. The benefits of aspirin overwhelmingly outweigh the risks. Do not stop taking it. The focus of this entire discussion and the change in guidelines is purely for primary prevention. This is for the millions of people who have been taking daily low-dose aspirin simply to prevent a first cardiovascular event. The question is, why did this once universal advice change? The truth is found in the landmark Aspirin trial and the subsequent updated guidelines from 2022 to 2025. The Aspirin study, focused on healthy older adults, delivered a shockwave to the medical community. It showed that for those over the age of 60 or 70, the daily use of low-dose aspirin provided zero benefit in preventing major cardiovascular events or extending disability-free life. Worse, it significantly increased the risk of serious bleeding events, particularly gastrointestinal and intracranial hemorrhage. The risk of a severe bleed suddenly became greater than the benefit of clot prevention. The United States Preventive Services Task Force, the USPSTF, responded with an updated D-recommendation. Do not start low-dose aspirin for primary prevention if you are 60 years or older. Yet because of medical inertia, the weight of decades-old advice, millions of seniors are still taking low-dose aspirin based on recommendations that are now outdated. If you are in this primary prevention group, the conversation with your doctor is urgent, but the stop must be strategic. The rebound science. To understand the safe stop protocol, you must first understand the true biological danger of sudden withdrawal. This is the rebound effect. When you take a low-dose aspirin, it permanently inactivates the cyclooxygenase enzyme, or COX-1, in your platelets. This enzyme is essential for producing thromboxane A2, the chemical signal that tells platelets to stick together and form a clot. Aspirin works by keeping your platelets from clotting too easily. The process of stopping is not instantaneous. When you suddenly stop the daily supply of aspirin, your body begins to panic, biologically speaking. It knows it has a large population of inactivated platelets, and it compensates by rushing to produce new, highly active, and sometimes hyper-responsive platelets. For a period, this new rush of platelet activity can make your blood more prone to clotting than it was even before you started aspirin. This is a temporary state of hypercoagulability. Research analyzing multiple trials has identified a critical window of vulnerability. The risk of a major thrombotic event, a stroke or heart attack, is found to be highest in the first 30 to 90 days after abrupt cessation. This is why simply throwing your bottle of aspirin away is not an act of health empowerment, it is a medical gamble. The transition requires a carefully managed, doctor-supervised plan. The 4-step safe stop protocol. We are now going to detail the 4 essential steps you must follow. Do not attempt this alone. These steps are designed to be your agenda when you next visit your primary care physician or cardiologist. Step 1. Comprehensive risk assessment. The decision to stop low-dose aspirin hinges on 2 competing risk scores. Your first action is to ask your doctor for a dual assessment. You need your ASCVD 10-year risk score, which measures your risk of a first cardiovascular event. If this score is below 10%, current guidelines strongly advise against primary prevention aspirin. Secondly, you need a bleeding risk assessment, often using the HAS-BLED score for general bleeding risk. If your bleeding risk score outweighs your low cardiovascular risk, only then is deprescribing, the planned reduction or stopping of medication, warranted. This first step is a data-driven checkpoint that validates your need to stop. Step 2. The controlled taper. The biggest mistake is the abrupt cessation, which triggers the rebound effect. The key to safety is tapering, or controlled reduction. While there is no universally adopted standard protocol for tapering, medical logic and emerging data suggest slowing the body's compensatory response. Instead of stopping immediately, discuss a 6 to 8 week tapering phase with your doctor. This typically involves either reducing the daily dose, though this is less common with low-dose aspirin, or more practically, reducing the frequency. A common approach is moving from 81 milligrams daily to 81 milligrams every other day for 6 to 8 weeks. This intermittent dosing allows a gradual cycling of newly active platelets, smoothing the transition and minimizing the hyper-responsive state. Step 3. Managing concomitant medications. Low-dose aspirin use often comes with other medications intended to protect against its known side effects. Specifically, many long-term users are also prescribed a proton pump inhibitor, or PPI, like omeprazole, to guard against gastrointestinal bleeding. It is absolutely crucial that you and your doctor coordinate the stopping of aspirin with the stopping of this ancillary medication. You do not want to continue a medication like a PPI if its only purpose was to counteract the risk of the aspirin you are no longer taking. Ensure your doctor reviews your entire medication list to remove any drugs whose purpose was tied only to your former aspirin regimen. Step 4. The 90-day vigilance period. Once you have completely stopped taking low-dose aspirin, your journey is not over. You must enter a mandatory 90-day vigilance period. This is the critical window where the rebound effect is most likely to occur. You need to schedule a follow-up appointment within the first month for a status check. More importantly, you and your family must be hyper-aware of the warning signs of a stroke or heart attack. This includes new or worsening chest pain, numbness or weakness, slurred speech, or unexplained vision changes. This period of vigilance is the final essential guardrail against the risk of abrupt change. Beyond the pill, the new primary prevention. The decision to stop low-dose aspirin is not a green light to ignore heart health. Instead, it is a forceful reminder that the true work of primary prevention must now be intensified using non-drug methods. The two greatest modifiable risk factors for cardiovascular events in older adults are high blood pressure and high cholesterol. The most evidence-based defense against a first heart event is the rigorous management of these two factors, often through well-tolerated medications like statins or antihypertensives. These interventions have shown clear benefits without the associated bleeding risk of low-dose aspirin. We must also issue a strong warning regarding over-the-counter pain medication. Many older adults replace aspirin with NSAIDs like ibuprofen or naproxen for minor aches and pains. These NSAIDs, I even use temporarily, carry a compounded risk of gastrointestinal bleeding, particularly when used immediately after stopping aspirin. Always discuss pain management options with your physician, recognizing the increased vulnerability of your digestive system during this transition. The new primary prevention is not about taking a simple pill. It is about lifestyle, vigilant monitoring, and patient-physician partnership. The risk landscape for older adults taking low-dose aspirin has fundamentally changed. For those of you on it, for primary prevention, the question is no longer whether you should stop, but how to execute a safe, deprescribing protocol. The thesis is clear. The greatest immediate danger isn't the bleed risk, it's the rebound effect from stopping it incorrectly. You now have the 4-step safe stop protocol. Take this plan to your doctor, advocate for yourself, and begin the safe process of managing your health with the latest medical wisdom. This is your control over your health. Now I want to hear from you. If you've been on a daily aspirin for over a decade, how does the thought of stopping or continuing make you feel? Share your personal plan or experience with Deprescribing in the comments below. But what are the best, scientifically backed, non-drug alternatives to protect your heart now that low-dose aspirin is off the table for primary prevention? I break down the top 5 supplements and essential lifestyle changes doctors are recommending in our next video, the 5 best natural supplements to replace aspirin's heart benefits doctor review. Click the link in the description to watch it next. And remember this crucial disclaimer. This content is for informational purposes only and is not medical advice. Always consult with your healthcare provider before making any changes to your medication regimen.